Hi, today is an exciting day. We are going to go over compliance stuff. My name is Melissa DeWeese, and I help employers maximize their employee benefit spend and efficiency in employee benefits. We'll go over the ACA, we'll touch on PPACA, a little bit of COBRA, and the recent Roe versus Wade and ERISA discussions. There have been some recent changes in regards to compliance, and then also as a refresher, I have found that a lot of my new clients are have some holes missing, so I want to touch on what some of the current compliance concerns are across the United States and bring them up to your attention, go over them, make sure that we address them, and put them on your radar. So let's dive in. One of the pieces that has dominated the medical insurance landscape since 2010 has been the ACA legislation, also known as Obamacare. It was the Patient Protection Affordable Care Act. Lots of different terms for it. It came into effect in March 23rd of 2010. There's a long list of huge health changes. I remember when it came out, it was terrifying to see this stack, and insurance as we knew it at that moment had changed forever. And there were penalties for non-compliance. At that time, there was a lot of fear coming from employers and brokers and health insurance companies, and we weren't really sure exactly how this all was going to play out. Now, this has cooled off, obviously. It's been over 10 years now since we've seen this, and so there's a lot more clarity around this piece. So let's just do a brief overview, go over this together, and see what's going on. And a lot of times my job is to poke holes in health plans and poke holes in processes that may not be working and encourage my employers that I work with to step up their game or do a little bit better in regards to limiting their liability. Because one of the biggest pain points and some of the riskiest times for employers are when they hire and when they fire an employee. And a lot of the benefits and the communications around benefits have to do with those critical times. So again, continuing on with ACA. So ACA came out with a list of essential benefits that absolutely must be covered under all health plans. Most of you have fully insured plans. These are automatically going to be rolled up into your insurance plans. Your carrier's taking care of this for you, so you don't have to worry about it. There were, prior to a healthcare reform, we had plans that excluded pregnancy and maternity. Those plans tended to be less expensive than those that included it. And in particular, I remember a plan that I sold quite a bit of where it only covered generic drugs. I had a lot of startup businesses in my portfolio of clients that I served, and they didn't need brand name drugs. There were a lot of young people on the plan. They only wanted generic, so we eliminated the brand name. We can't do that anymore. We can't carve out benefits and customize it to the group. It's more of a one-size-fits-all model for those that are fully insured. And you'll hear me talk about fully insured versus self-insured. A fully insured plan is a plan that you go to the insurance company and buy a plan with everything included. You've got PBM, which is your pharmacy management. You've got your claims processing. You've got your network already built in. You have Blue Cross or Blue Shield or whoever. All that's already packaged into a fully insured plan. And with that, you get state compliant plans and ACA compliant plans in most circumstances. With self-funded plans, you are subject to ERISA, which is more federal legislation, and it's a different set of rules and regulations because they're not governed by state regulations. So there's a lot of really interesting things going on depending on which category you fall under. But most plans fall under these ACA guidelines, and they have to provide ambulance services, emergency services, hospitalization, pregnancy, mental health, prescription drug benefits, rehabilitative, laboratory, preventative, and pediatric services. And with this, a lot of us saw preventive services going forward from, I think it was implemented in 2012, where plans had to cover preventive services at 100%. And then we get into you must have health insurance, right? That part of the ACA was trying to really do as much as they could to get people enrolled in health plans, because the idea is the rule of large numbers. The more people that are covered, the more that the cost will be distributed amongst a larger population. If you have all the healthy people opting out and not contributing, the idea is that all of the people that are sick are now paying the brunt of the cost of the medical insurance, and therefore the entire population of the United States, it's weighted where the people that are healthy are not paying anything because they don't see the point in getting insurance, and those that are sick are paying an arm and a leg to get their coverage. So the idea was, I'm not saying that's what happened, I'm saying that was the intention. The idea was to get as many people enrolled. So one way to do that is with a carrot and a stick, right? You have a carrot, which is a positive reinforcement strategy where it's a drive towards, it's behavior change strategy where you use a benefit, money, subsidies, tax credits to incentivize people to enroll. And then you have penalties for those that don't enroll. And there were penalties put into place for groups as well as mandates for the individual. So this talks about a definition that's skirting around to the fact that large employer in regards to ACA is an applicable large employer. And you have to calculate what's called full-time equivalence. So there's lots of definitions for full-time and part-time and large group versus small group. And in this context specifically, we are going to be talking about ACA and what ACA means when they say large employer. So calculate the FT, the full-time equivalent of part-time employees, by adding up the total hours worked of those part-time employees and then dividing it by 120. So you may have a list of part-time employees, and let's say you have 100 part-time employees and 5 full-time. In order to figure out if you're a full-time employer according to ACA, you have to take that 100 employees that are part-time, add up all their hours and divide that by 120. And whatever that number is, you have to add it to that 5 of your full-time employees. So if that's over 50, then you are an applicable large employer. Congratulations. And you have some additional regulations that you have to worry about. I pulled a lot of this just directly from the IRS website. So under the Affordable Care Act, you have a shared responsibility. And certain employers, which are ALEs, applicable large employers, must offer minimum essential coverage that is affordable, that provides minimum value to their full-time employees. So if you're a large employer over 50 employees, you have to offer minimal essential coverage that is affordable. So there's some affordability guidelines. You cannot charge an employee more than 9.5% of their household income. And there is a safe harbor for that, because if you think about it from the employer's perspective, you're an HR person sitting behind that desk, and you have to abide by all these privacy regulations and employment laws. You are not allowed to ask your employee what their household income is. That's none of your business. The only thing that is your business is to know what your employees' earnings are, because you are part of that paycheck process. You're paying that employee. So there is a safe harbor for that. So you can take the employee's W-2, prior W-2, or their expected earnings, and times that by 0.095 or 9.5%. And as long as the employee is not being charged more than that in an annual expected annual cost of more than 9.5% of their earnings or expected earnings, then you are providing affordable coverage. So I know when I talk to people, and in layman's terms, people think of affordable in one way. However, affordable in this context means something totally different, and it is clearly defined under ACA. And there's also additional reporting requirements. So if you are an applicable large employer, you do have to do some ACA filing, and there are penalties if you are not doing that filing. So ALEs are subject to the employer shared responsibility provision. Whether an employer is an ALE or in particular calendar year depends on the size of the employer's workforce in the preceding calendar year. So what that means is that you look over the prior calendar year. So right now we are in 2022. So you look at 2021 and come up with your employee count for every single month. You add up all those numbers. So one month it's 50, and then it's 30, and then it's 75, and then it's 20, or however, add all those 12 months up of what your count of the employee was of each month and divide it by 12. Okay, so if you have averaged above 50, you are now an ALE. So that's how you determine if you are an ALE and when the timer starts. Okay, so the prior calendar year. And the total number of full-time equivalent employees, so that just goes over this calculation. So FTE review. So full-time employee for any calendar month is an employee who has on average at least 30 hours per week of service. So when I talk to employers about full-time employees, a lot of them automatically think 40 hours a week. However, under ACA, it's considered 30 hours a week. So if you have a list of 100 employees and 5 of those are 40 hours a week and 10 of them are 30 hours a week, you technically have 15 full-time, and then the rest are part-time or possibly variable hour, and we'll go over that as well. If you are falling above the 50 mark, it is time to consider whether or not you're going to offer minimum essential coverage. Otherwise, and you're basically looking at pay or play, and I'll go over that as well in just a moment. Now, sometimes what comes up when we're looking at demographic data of an employer is who is seasonal. So we can exclude the seasonal employees from this number and think of season as a season. Summer, winter, fall, and spring. And how long do those seasons last? A quarter, 120 days. So if you have employees that have come on for a season, literally 120 days, and then they've left, that is a seasonal employee, and you do not have to count those in your calculation for your FTE. So hopefully that might get you below the 50 so that you don't have to worry about any of this stuff. Then it's defining a variable hour employee. You might also have employees that sometimes they work 20 hours a week, sometimes they work 42, and then they work 15, and it's all over the place. When you hire them, you are not certain as to exactly how many hours a week they're going to work. It's on demand. It varies. So with those, you will have to do a variable hour calculation and determine what your look back period is going to be. And whatever your look back period is has to match your stability period, and then you come up with a measurement period and a administrative period. So we're going to go over all these periods together, and I'm going to give you some examples to bring this one home, to give you some context so you can understand what the heck all these terms mean. So the monthly measurement method. Under the monthly measurement method, an employer determines whether an employee is full-time by counting the employees every single month. And because your measurement period has to match your stability period, you could have people coming on and off your plan every single month. And because of that, many employers opt for a different strategy. So you can basically, what this is saying is you can basically do a monthly measurement period or a look back measurement method. Most people do the look back measurement method, and we will go over that here. So a look back measurement period is typically 12 months, because if you do the monthly method, you're calculating your variable hours every month and their stability period is the same. So that means that people could be coming on and off the plan every month. And that can be an administrative nightmare, especially if you have high turnover. But if you look back period of 12 months, every month you can look over the past 12 months and you might have one come on, and then the next month you might have two come on, and the next month you might have zero. So it gives you some time to really assess if that employee is going to stay with you long term, for one, and two, to eliminate the on and off the plan and COBRA notices and all of the additional administration that comes with adding employees on and off, on and off, on and off. So when the stability period is for the January 1st plan year, the best approach is to measure the period that runs from November 1st through October 30th each year. The rules do allow an administrative period in between the measurement and stability periods. So when you're looking back over that 12 months, you have that 90 days to get them enrolled on the plan. So you've done that 12-month look back period, you've established, okay, there's 3 employees that are eligible for coverage. You now have 90 days to get them all their plan information and get them enrolled on the plan. So in this example, for this January 1st effective date, their measurement period is November 1st through October 30th. Then November and December, they chose a 60-day administrative period, even though they could have picked a 90-day. And then the stability period also has to be 12 months because they used a measurement period of 12 months. So the measurement period and the stability period have to be the same, or at least the stability period has to be greater or the same. And then, so they go from 1/1 to December 31. So that aligns nicely with their renewal and their open enrollment. The initial measurement period can begin on the date of hire or the first of the month following the date of hire. So the employer has 12 months measurement period for newly hired employees. The admin period could only be 1 month in order to comply with the 13th month rule. Here is an example for an employee hired for 15. So in this example, we have a measurement period starting May 1st because you want to start the measurement first the month following the date of hire, because most plans don't have all this prorated costs. So if someone enrolls in a partial month, a lot of plans don't do that. Whenever you become eligible for a plan, it's usually first the month following, so we don't end up with partial premiums because that can get really confusing administratively. So the initial measurement starts in this example May 1st of 2022 and runs through April 30th of the following year. So it's a full 12 months. And during that first year of that person's employment, you do the measurement. If they fall over the 30 hours per week on average, then the admin period starts. And here they give a 30-day, they chose a 30-day admin period. And the stability period is also 12 months. We have some ongoing compliance that we do as a result of ACA. So we've got in-network out-of-pocket maximums that are adjusted every year. So if you currently have an ACA compliant plan, you probably have a bronze, silver, gold, or platinum plan in your name. And those, you'll notice the max out-of-pockets are adjusted every year, and they're adjusted for inflation. So in 2021, the max out-of-pockets were $8,550 for an individual and $17,100 for a family. That's the max out-of-pocket. And then in 2022, the max out-of-pocket is $8,700 for an individual and $17,400 for a family. Excise tax on rich benefit plans. So if you are not aware, this originally was supposed to come out 2018. There was going to be a 40% tax on plans whose health insurance premiums exceeded $10,200 a year. So if your premiums were, let's say, $15,000 a year for an individual, that $4,800 would have an additional 40% tax on it. This went away. It was originally going to be in effect January 2018. Everyone hated it. Part of the reason why they pushed this through was to balance out the budget, because ACA was pushed through as a budgetary type of legislation. And so they had to make sure the budget was balanced, and they used this piece to balance it out. And now we don't have it. So this has been eliminated. It was originally going to come out in 2018. It got pushed to 2020 and then to 2022. And then in 2019, right before COVID, and as COVID was kind of, the buzz was happening over there in China, the Secure Act was passed, and part of that was the elimination of the Cadillac tax, which everyone was partial to. So ongoing requirements, we still have the pay or play mandate. The pay or play mandate originally came into effect in 2015, and it started with a $2,000 and a $3,000 fine per employee, depending on whether or not you offered affordable coverage. So now the fine is $2,750 for the fine that was originally for $2,000, and then for the fine that was $3,000, that's been adjusted up to $4,120 per year. And again, with this one, I find that the best way to understand how these fines work is to go through some examples, and I pulled some examples specifically put forward by the IRS, and we'll go over that in just a moment. The SBC, so Summary of Benefits and Coverage, they are not benefit summaries. These are, the intention was to help people understand how their plans worked, to give specific examples at the end. In my opinion, it doesn't accomplish that. I think it just adds more paperwork, and I was fine with the benefit summaries. Fully insured plan non-discrimination testing. So employers, those of you who are self-insured or have an HRA, you are already doing non-discrimination testing, because non-discrimination testing is required for plans governed under ERISA. And so if you'll remember, in the beginning of the presentation, we've got fully insured, self-insured. If you're fully insured, you're governed by state regulations, and if you're self-insured, you are under ERISA and you don't have to comply with state, but there are other regulations that you do have to comply with, one of which is the non-discrimination testing. Non-discrimination testing for self-insured versus fully insured. So this is an IRS code 105H, and self-insured medical plan reimbursement plans must pass 2 non-discrimination tests to ensure that the plan does not favor highly compensated individuals. And there are several methods to walking through this, and we'll go over some of those here in just a moment. And this right now only applies to self-insured medical plans, which does include HRAs and medical expense reimbursement plans, also known as MRPs. The ACA stated that it wanted to make this non-discrimination testing for all health plans. However, the regulations haven't come out. It said we will provide additional regulations and guidance, and then that just never came. So we don't know if it's ever going to come at this point. So we've got test 1 is an eligibility test. So I believe it's just one of these that you have to comply with. So it's method 1, which is a 70% test where 70% or more of all of your employees are benefiting from the plan that you're offering. Method 2 is a 70-80 test. If 80% or more of your employees are eligible under the plan, then at least 80% of those have to be participating in the plan. Okay? Very similar, but different. Method 3, non-discriminating classification. So if you are classifying your employees and allowing those classes to participate in your plan in a non-discriminatory way, and you're not favoring highly compensated individuals, then that's also passing a test. Test number 2 is that you have to pass is benefits provided to so HCI is highly compensated individuals must also be offered to all other employees. So when we say all other benefits, that means non-executives or non-HCIs or highly compensated employees. And that includes for benefits and reimbursements. So reimbursements or benefits cannot be in proportion to age, years of service, or in relation to the employee's compensation. Employee contributions should be the same for all benefit levels, so meaning all classes basically. And waiting periods should be the same for all. Highly compensated individual, HCI, is an individual who is one of the 5 highest paid officers. A shareholder who owns more than 10%. Highest paid 25% of all of the employees. So the following employees can be excluded from the top 25%. So employees who have less than 3 years of service, employees who are less than 25 years of age, part-time employees, collectively bargain employees, and non-resident aliens. Individual mandate. So this one has had a lot of news around it since its inception, and there's always talks of it going to the Supreme Court and ACA is going to go away, and basically the mandate has been declawed as of 2017. Yes, 2017. The penalty is 0. So although we still have to submit our forms showing that we had insurance over the last year when we file our taxes, there is no penalty for not having medical insurance anymore as an individual. A lot of business owners and employees alike get confused between the penalties for payment for employers versus the individual mandate. Supreme Court in 2012, it was taken to 2012, it was ruled constitutional. In 2015, again, it was taken to the Supreme Court. Again, it was shot down, the contesting it as being constitutional. And then in 2017, the Congress passed Tax Cuts and Jobs Act, which reduced the penalty to 0. Then it went to the Supreme Court again, and the Supreme Court dismissed the challenges against the individual mandate and threw it out. As of today, technically the mandate is still in effect, but it is a $0 penalty. And here's a little bit of history. In 2014, 8.1 million Americans paid a fine for not having insurance as opposed to obtaining qualified health coverage. The average fine was just $210 for the entire year. That was the average payment for an individual. This number climbed year over year, and in 2016, the average fine for an individual was $667 annually. In 2018, the fine for a family of 4 who did not have health insurance was $2,085. And there is no cap on the fine other than it could not exceed the average cost of the lowest tier offered, which is a bronze plan. Some interesting history there, and the ALE payment. So the ALE payment is specific for those applicable large employers of 50 or more FTEs. If they are offering health insurance coverage, there could be a fine, and if they're not offering health insurance, there could be a fine. Basically, for those that are not offering health insurance, it's a $2,000, which is now $2,750 per employee fine. And if you are offering health coverage and you mess up on one of your employees, it's that $3,000 fine, which is now $4,000 and some odd dollars. Okay, so even though the fine is more per capita for those who are offering and trying to do the right thing, usually it's less of a fine because they don't have as many mess ups as the one that's just saying, we're not going to follow it, so they get fined on all of the employees minus the first 30. And then those that are offering coverage only get fined based off of the number of mess ups there were. Okay, so we're going to go over just some examples here. So this is from the IRS website. Company K has 70 full-time employees of each month in 2017. Company K does not offer minimal essential coverage. So they're saying, we don't want to deal with it. We are just going to take the fine. So in the pay or play mandate, they have decided to pay as opposed to play. So this is a pay example. One full-time employee obtains health insurance through the marketplace and receives a premium tax credit for each month in 2017. So this is the trigger. So a lot of employers go by and think, oh, we're not getting any penalties, not a big deal. Wait, there's more. As soon as the employee goes and receives a premium tax credit, that usually flags this whole process. And because Company K does not offer minimal essential coverage to at least 95% of its full-time employees and their dependents, for each month of 2017, and at least one full-time employee received a premium tax credit, which is the trigger, Company K is now subject to the first type of employer shared responsibility payment or penalty described above. So for 2017, Company K is subject to an employer shared responsibility payment of $80,000, which is calculated as follows. So the number of full-time employees, 70, minus the first 30, so you don't have to pay for the first 30. You times that by 2,000, which is now, I believe, $2,750. So it would be more now. They use old examples in these IRS examples. They haven't updated them. This example does not reflect the inflation adjustment for the 2000, like I just said. ALE payment example number 2. Company M has 125 full-time employees, and for each month of 2017, it offers minimal essential coverage to its full-time employees. They've decided to play. They're trying to do the right thing. But the minimal essential coverage is not affordable for all of the employees. 14 of its full-time employees, so remember the affordable, it doesn't meet that 9.5% standard safe harbor of the employee's annual income. So that's how they deem if it's affordable or not affordable. That's how the IRS determines if you're going to get this fine or not. 14 of its full-time employees obtain health insurance through the marketplace trigger and receive a premium tax credit. Because Company M offers minimal essential coverage to its full-time employees and their dependents, it is not subject to the first type of employer shared responsibility payment or penalty described above for any month of 2017. However, Company M is subject to the second type of employer shared responsibility payment or penalty described above, failure to offer affordable, minimum value, minimum essential coverage for each month of the year, because for each month of the year, at least one full-time employee received a premium tax credit. So the trigger, again, is the employee going to the exchange, Covered California or any of the other exchanges out there offered through the state, and received a premium tax credit through the state. That is a trigger for them to go to the employer and get the fine. Company M is subject to an employer shared responsibility payment of $42,000, calculated as follows. Number of employees who receive the premium tax credit for each month of the year, 14 times 3, so $42,000 is their fine. ACA and ERISA. So ACA does not affect church and government plans. ERISA comes with its own stack of compliance standards where you have to supply a written plan document, plan summary, compliant claims and appeal procedures, and plan administrators have fiduciary duties. So that is for the self-insured out there. Then we got the Security Act, or the Secure Act. This act, which I already mentioned before, eliminated the Cadillac tax that was in ACA, and also removed the health insurance tax on insurers for fully insured plans. So there, for several years, there was an additional tax fee, almost looked like a sales tax there at the bottom of your invoice, that included, I think it was 2% or somewhere around 2 or 3% for insurance tax on fully insured plans, and that was removed. There was also a PCORI fee, which was for HRA plans and self-funded plans, which started at $2 per employee per month. And I did a whole other video on that. If you want to know more about PCORI, I'm not going to dive into it here, so you can click and learn more if you're interested. They removed the 2.3% excise tax on durable medical supplies or medical devices, and proposed regulations on transparency. So that was the Secure Act. Then we've got other considerations such as COBRA, ACA filings, ERISA, and then what I wanted to touch on today is the Roe versus Wade impacts. So as a brief overview, we've got multiple laws. So there's many states that have conflicting laws right now. We've got trigger laws, pre-Roe versus Wade laws, and laws that have been written after Roe versus Wade. And a lot of the questions are which laws are the controlling law. A lot of attorneys are trying to figure this out, especially for plans that operate across state lines. Maybe you have an employer in California and then they have employees in Texas. How are those employees in Texas going to be affected by these changes? And is the employer liable or criminally responsible possibly for offering coverage for abortion in Texas? IVF could be impacted. So in the benefit where you have in vitro artificial insemination, you could have multiple eggs fertilized, and now you have multiple embryos. What happens to those embryos, depending on the state that you're in? What's the legislation around that? You know, things are going to change in that area for sure. Are there criminal penalties, civil and criminal penalties for plan sponsors that are offering? There's a lot of employers that are offering travel benefits as a result of Roe versus Wade. Employers' response to Roe versus Wade. So many employers have expanded medical travel benefits and services. They've expanded telemed services. They've expanded coverage for elective abortions. They've put restrictions of coverage to only what is required under federal law, which I'm going to go over here in a second. So you kind of have two sets of employers. You have the employers that are expanding benefits in this area and accommodating travel for abortions as much as they can. And then you have other employers that say, we don't want to touch this with a 10-foot pole. It's not our responsibility. So we're just going to restrict coverage and be super conservative and only cover what's required by federal law until this whole thing blows over, right? Until more, and you'll find out why here in a minute. Include a blanket plan exclusion for coverage of any illegal items or services. Keep in mind too, for those that are upset over the Roe versus Wade being overturned, is that the employer is taking on additional liability. If they have an employee, like I said, in Texas, and they're offering coverage or travel benefits for them to exit the state to have an abortion, there could be criminal charges in that context. So it's completely understandable for an employer to take either stance on this one. Self-funded has more flexibility. So If you're self-funded, you're going to have a lot more flexibility in this because you build and design your plan anyway, and 2, you are under ERISA versus state legislation. So if you are fully insured, you're not going to be able to tweak the existing major medical plan. You're going to have to add plans underneath it, like an HRA or something like that, to fill in travel benefits. But if you're self-funded, you can add it directly into the major medical plan, and so it's one plan, one administrator, one claims administration process, and it just turns out to be a lot cleaner that way. Federal law coverage requirements on abortion. So there's no required coverage of elective abortions, okay? But there is the Pregnancy Discrimination Act that it states that plan sponsors must provide benefits for abortion where the life of the mother is endangered. Okay, those are usually like tubal pregnancies and things like that, right? Then we've got provide benefits for services for medical treatment complications that arise as a result of an abortion or a miscarriage. So if there's a botched abortion or something bad happens out of state, let's say a woman goes from Texas to California for an abortion, comes back home to Texas and has some additional bleeding for whatever reason, starts bleeding at home, right? She's states away from where she received the original abortion services, and they are required to treat her under federal law for that, okay? So state insurance laws, it's fully insured plans must comply with state regulations. ERISA is for the self-funded plans, which we've gone over several times. So travel benefits for medical care, there's tax implications. So there's some questions about travel assistance and how that can be arranged to be a tax-free benefit according to the IRS, right? So there's lots of, talk to your tax professional. This is not tax advice. I'm not an attorney. Seek legal counsel with all this. I'm just here to bring up discussion topics and bring things up to your awareness, and like I said, find potential holes and liabilities that you might concern you. And there, just like with ACA, how there's different definitions for full-time and for large employer under ACA, there's different definitions for even just those terms in different contexts. And same goes for benefit, is defined differently with ACA and ERISA and HIPAA and HSA and FSA and HRA and tax laws, and then also what other implications are there with COBRA. If you're offering an additional travel benefit and it's a benefit, it has to be offered through COBRA. So if an employee terms, now you have to offer that as a continuation of coverage under COBRA as well. And you have to price that out accordingly. Option 1 of what we're seeing is expanding additional travel benefits under the existing medical plan, which I already kind of talked about. That would be if you are self-insured. This is probably what you can do. There are going to be some group plans that will allow you, and I'm sure there's going to be riders that are come out relatively soon once all of the attorneys comb through stuff at the insurance companies and figure out what they're going to do. There's going to be all kinds of riders that employers can add on with fully insured plans as well. But right now it seems that the self-insured plans have the advantage and can do, make changes accordingly on the fly. Option 2, HRA that is tied to the major medical plan. So building out a health reimbursement arrangement. It's basically completely funded by the employer. It's 100%. It's a fund that's created by the employer that the employees can submit qualified claims and or receipts to receive reimbursement. This could affect somebody's HSA eligibility. So you may want to tie this benefit after the deductible has been met in those cases. However, using a TPA that is HIPAA compliant, because the last thing you want to do, some people are suggesting, have your people do this in-house. I don't agree with that. I think that this is definitely something that needs to be administered by a TPA. I don't think that employees should have to go to their employer and tell them that, hey, I want to have an abortion, and then get reimbursed by travel expenses. I just think that's a really tough conversation for somebody to have, especially with their employer. I think there's a lot of liability there for the employer if they go that route. If you insist on having a reimbursement plan for travel benefits, I believe that you should pay for a good TPA, make sure it's HIPAA compliant, stay out of it as much as possible, and make it a general benefit for all travel benefits for services, for medical services in which you are not able to seek treatment within a certain mile of radius from your home or work, possibly defining it that way. Accepted, which would be great for anybody else. So not just in context where somebody has, a condition where they are having issues getting treatment for anything, a cancer treatment, abnormal illness or disease. If they could travel somewhere else, and oftentimes too, traveling to another state, it might be less expensive. So there's other areas where travel benefits have been used before. It's not just for this context. This is nothing new. They've called it medical tourism, has been around for a long time. I'm not suggesting people go to Mexico or some other country, although that has been suggested with medical tourism before. But even just going, let's say you're in New York and traveling down to Florida, services for certain procedures and surgeries might be less expensive in Florida, or the employee might have family that can take care of them post-surgery out in Florida. A lot of people go back and forth between Florida and New York. So this might be a good general benefit to have anyway, regardless of Roe versus Wade and all that happened with that. So there's lots of questions regarding new travel benefits that a lot of us are going over with our clients. So if you're offering broad travel assistance, or if you're offering a travel benefit, are you offering broad travel assistance? Will this be conditional coverage? I'm not suggesting that anybody get very specific with this. I don't think it's a good idea. I think that it shouldn't just be I think it'd be very problematic if you make it just for abortion and reproductive services. I think it can cause a lot of problems. If you make it more of a broad benefit where people are able to travel for, like I said, other services, whether it's conditional on, there might be a couple of conditions that have to be met, like coverability is better in another location, cost is better in another location, perhaps services aren't available within a 30-mile radius of your house, things like that. You might have a set of conditions that you put on this money, and I've noticed that a lot of people are aiming for the $4,000 benefit. This is basically a copycat from Amazon. Amazon was the first that really brought out some PR around this and went to the $4,000 mark. So other employers have copied that. Will there be an annual cap or a lifetime cap? So either one is perfectly fine. Will there be a limitation of coverage for travel benefit only if participation in X radius of home or work? I already went over that. Travel benefit, is the employer liable or criminally charged? So we don't know. If you are an employer, let's say in New York, and you have employees in Texas, and you pay for somebody to go out of state to, let's say, California to get an abortion, could you be civilly or criminally liable? Nobody knows. Nobody's gone to court. This can be serious stuff. So it's a risk and it's a liability that certainly is there. So knowing that ahead of time before you're making any of these decisions, I think is important. And unfortunately, I think that a lot of people are being a little bit reckless with this and just throwing money at it and not really thinking about the long-term repercussions. Other considerations could be notices and COBRA, and some of the other notices that we already talked to you about. With that, thank you so much for hanging out with me today. I know compliance, legal, mumbo jumbo can be quite dry, so I appreciate you hanging out with me today. If you have any questions at all and you're a client, please click the link down below where it says schedule a call with Mel. I've highlighted my link there. If you're not a client, I do ask you to fill out a quick questionnaire. Your time is valuable, so I want to make sure that I'm the right fit and that it's a question that I can actually help you with. And if I can't, I can usually refer you to someone that can. So with that, that's all I have for you today, and I will see you next time.